Good morning. I'm Clea Colombo from Brazil. It's a pleasure to be here. Welcome everybody to EAPC Sports Cardiology course. So it's my pleasure to introduce Dr. Domenico Corrado to talk about It's All in the Depolarization.
Good morning. Thank you for inviting me to this very important meeting. And so it is not all in the depolarization, but good parties. As shown by this table reported in the first European Society of Cardiology recommendation for interpretation of athlete ECG, where you can see here that among the group of ECG abnormalities that were considered unrelated to training and potentially associated with the risk of sudden cardiac death, more than half concern depolarization, electrical depolarization of the heart. So physicians who read the atlas electrocardiogram must pay attention to the morphology, duration, and amplitude of the QRS, with particular regard to the first part of the QRS, the mid part, and the terminal part of the QRS. So they should pay attention to the first part of the QRS with regard to the presence of the so-called delta waves. There's slurring in the first part of the QRS, as you can hear, that reflect the presence of ventricular pre-excitation in the setting of Wolff-Parkinson-White syndrome. This delta wave and pre-excitation is related to the presence of an accessory pathway that connects the atrial myocardium with the ventricular myocardium. When the anterograde refractoriness of this accessory pathway is short, there is the risk that in the presence of an atrial fibrillation, there is a very rapid conduction through the accessory pathway that can degenerate into ventricular fibrillation. So another ECG abnormality that should be considered is the presence of pathologic Q waves in the first part of QRS. That means Q waves, negative waves, that usually are large and or deep in 2 or more ECG leads. This Q wave, pathologic Q wave, reflects the presence, usually the presence of a scar. Usually in adults is a post-myocardial infarction scar, but in younger individuals and athletes may be expression of a scar in the context, for example, of a myocardial hypertrophic cardiomyopathy. As you can see here, this is a macroscopic view of the scar, the histologic view of the scar, and in this patient there were pathologic Q wave in the septal leads, and of course this scar acts as a substrate for ventricular fibrillation in these affected individuals and athletes. With regard to the mid part of the QRS, first of all, we should consider the duration, because the duration is associated with a potential conduction disturbance. You can see here, for example, that an increased duration of the QRS with the left bundle branch block morphology, like in this case, may be associated with a cardiomyopathy, usually dilated cardiomyopathy. That, of course, is a disease at risk of sudden death due to arrhythmic sudden death, but also heart failure in athletes. So with regard to the amplitude of QRS, we know that increased amplitude of QRS is physiologic, is normal, is part of the common train-related changes of the athlete's electrocardiogram. Instead, is important is an emerging ECG pattern, the reduction of the QRS amplitude, low QRS voltages, especially in limb leads, as you can hear, very low, less than 0.1 millivolt in this case, that we learned, thanks to cardiac MRI, we learned that this ECG pattern is associated with the scar. Look at ring-like pattern, non-ischemic, subepicardial scar, that probably reduces the mass of a myocardium that is electrically active and takes account for the reduction of the electrical amplitude of the electrocardiogram. So how common is this ECG pattern among the normal population? in order to understand the potential difference, the potential clinical significance of these abnormalities. According to this study, from a collaborative study from Italy and the US, we demonstrate that low QRS voltages in limb leads less than 0.5 millivolt is present in less than 1% individuals. That means athletes, Italian general population, athletes either white, Caucasian, and black athletes. This is important because it's very low prevalence in this population. Compared with the diseases, cardiomyopathies, in which there is a scar, because usually this pattern is associated with a scar. So in other words, there is a large difference. And the athletes, very few athletes with this pattern, when perform a cardiac MRI, in the presence also of premature ventricular beats and other abnormalities, show the presence of a scar. So the specificity seems to be very good. We can discuss which is the best way to investigate these athletes, if perform other investigation or to go on with the cardiac MRI soon. So in the terminal part of the QRS, the physician reads the electrocardiogram should pay attention to these patterns. Post-excitation waves, also known as epsilon waves, look at this. This is a small amplitude electrocardiogram after the QRS and before and during the ST segment. That is a marker of a cardiomyopathy, especially when associated with this other pattern that is called terminal activation delay. We are dealing with the right precordial leads, V1 to V3. This is the pattern that is terminal activation delay is associated with a delayed S wave upstroke, as you can see here. Look at delay, okay? So epsilon waves and this delay is highly specific for a condition that is called arrhythmogenic right ventricular cardiomyopathy that is associated with a scar in the right ventricle that influence the conduction through the right ventricular wall. Another important pattern that you can find associated with epsilon waves and terminal activation delay is a QRS fragmentation, like this in V1 to V3 that is often present in the context of this cardiomyopathy. So of course the scar or arrhythmogenic cardiomyopathy may generate ventricular tachycardia and sudden arrhythmic death. What about QRS fragmentation? So if we exclude the QRS fragmentation in the context of arrhythmogenic cardiomyopathy that's usually associated with the post-excitation waves and terminal activation delay, and we exclude incomplete right bundle branch block that usually is characterized by this pattern, RSR1, okay? The presence of multiple deflection of the QRS, as you can see here, these are a number of examples, is very uncommon in young athletes. We found that is about 0.5%. We found only 10 of athletes with fragmentation of QRS in 2 or more leads. That is very low. So when it's low a QRS abnormality, we should suspect that this may be expression of a pathology, of an abnormality, of course. But at the present time, we don't know exactly if this abnormality, if you exclude right precordial leads and incomplete right bundle branch block, may be actually associated with a cardiac pathology, because in this study, the affected athletes were not investigated with cardiac MRI and other conditions. So is a CG pattern that merits further examination on larger population in order to understand which is the clinical meaning of this condition. So the last depolarization abnormalities is one more depolarization, premature ventricular depolarization. Premature ventricular depolarization. So that, of course, the physician must pay attention on. So this premature ventricular beats, so premature ventricular depolarization, is important because may be expression of electrical instability of the heart. And the physician who reads the electrocardiogram must first of all consider the morphology of the QRS, because some morphology are common, are benign, and not associated with the cardiac pathology. This morphology are expression, usually are expression of the so-called idiopathic ventricular, preventricular beats. The morphology is left bundle branch block and inferior axis that account for more than 80% of preventricular beats in young individuals and healthy athletes. That means the preventricular beats originate from the right ventricular outflow tract, and right bundle branch block and superior or inferior axis that the so-called fascicular preventricular beats that is characterized by a very short duration of a QRS, less than 130 milliseconds. These two morphologies are benign, idiopathic, associated with a good outcome. Instead, these abnormalities, these morphologies, that means left bundle branch block and superior axis, or right bundle branch block and superior axis, with the wide QRS instead may be associated, may reflect an underlying cardiac disease at risk of sudden cardiac death. We published, together with John Dresner, proposed this diagnostic algorithm, is my last slide, that is based on the concept that the outcome is influenced by the morphologic pattern of the ectopic QRS and the response to exercise. And this is the algorithm. You can see here that the importance of the morphology of the premature ventricular depolarization, the importance, you can see, is this stage of the algorithm. So in other words, all athletes with premature ventricular beat should be evaluated by the first line examination that include echo, exercise testing, and so on. And only those, if you find abnormalities, of course, it's a different way. But those without abnormalities, the first line examination, with just premature ventricular beats, okay, should be further investigated by complex, expensive evaluation like a cardiac MRI, only if the morphology is uncommon, not idiopathic. While those with the common morphology should have no problems with continued day sport activity. Thank you for your attention.
Thank you, Dr. Corrado. Any question from the audience?
Can I just get it started? So, Prof, you say about the morphology of the PVBs. The reality is that we do a Holter monitor, for example, and even if it's a longer one, and we see different morphologies, what's the definition of how do I decide if it's RVOT or if it's something else, if I've got more than one?
So it's difficult to say, to establish a cutoff. Usually is the prevalent morphology. I think that the most important finding is the morphology during exercise testing for an athlete. Because we saw that, for example, to find premature ventricular beats with the morphology, right bundle branch block and superior axis, okay, is highly predictive of a scar in the inferolateral wall of the left ventricle that is not ischemic or it's a cardiomyopathic scar. So in this particular case, it's important. On the Holter monitoring, it's important to evaluate the morphology. And usually, if the mechanism is an ectopic focus generating, for example, in the right ventricular outflow tract arrhythmia, usually there is a monomorphic. There are very, very uncommon different morphology. If you have different morphology, of course, you have to decide which is the best, the most prevalent, using different tests like exercise testing, Holter monitoring, and so on.
Nick Bijsveld from Amsterdam. When you see an uncommon PVC, you're not able to do an MRI because it's limited. Do you think an echo with strain is also sensitive enough?
For time reason, I didn't explain all the algorithm. So all athletes with premature ventricular beats must undergo first to echo. because echo may, of course, demonstrate the presence of gross cardiomyopathies, for example, hypertrophic cardiomyopathy, dilated cardiomyopathy, and so on. But the problem is that this emerging cardiomyopathy that is scarring arrhythmogenic left ventricular cardiomyopathy is characterized by this scar, segmental scar in the left ventricular wall, escapes echocardiogram evaluation because the regional contractility is not affected. Because usually it's the subendocardial part of the wall that, account for the contractility, the wall motion. In other words, the echo may be normal. So you need cardiac MRI to demonstrate this scar. But it's important to find, in the context of pre-participation screening, pre-participation evaluation, which are the ECG abnormalities that can predict this scar, because we don't perform cardiac MRI to everybody, okay? But if morphology is, for example, the morphology you said, we usually perform cardiac MRI, and the predictive value of this morphology, when the premature ventricular beats occur during exercise, in other words, is adrenergic dependent, is highly predictive.
Thanks very much.